Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Today is the 7th of April, 1987, and we're in Ann Arbor, Michigan with Dr. Bob Ricketts. Purpose of today's talk will be to sort of turn the tables on Dr. Ricketts, who has interviewed so many famous people over the last 10 or 15 years. I want to welcome you and thank you very much for coming.
Thank you.
Today I think what we'll do to begin with is to start out by having Bob tell us a little bit about his own background and how he got involved in orthodontics. And then as we go, we'll get into more substantive issues with regard to orthodontic treatment today, in the past, and hopefully in the future.
Well, first of all, Jim, I'd like to thank you for the opportunity of being interviewed. As we said, I'm still at an age maybe where I still have my faculties.
I hope so.
Hope so. I suppose the best way to describe my interest in orthodontics per se was going back to my sophomore year in dental school, when the first lecture I heard in orthodontics was by Tom Spidell.
Really?
He was head of the department at that time at Indiana University, and I felt that orthodontics was the ultimate challenge in dentistry. So at the level of a sophomore, I had an interview with the dean, who was Dr. Bill Crawford at Indiana University. And I told him that I was interested in orthodontics, and I was probably going to be interested in graduate work and in research. And he, all at once, he almost came out of his chair and applauded me and laid back and says how glad he was that, because he had helped me through my career from football into dentistry, and it was a very difficult task for me to make it. We learned at that time, we had technique courses in labiolingual.
Really?
So the first technique that I learned was labiolingual technique as a student at Indiana University.
Mm-hmm.
Then my senior year, I had the opportunity to actually start practicing orthodontics in dental school.
Really?
Yeah.
Was that through the orthodontic department?
Yeah. And the reason for it was that Spidell had left. He had taken over a deanship at Loyola in New Orleans. And there was nobody to treat the cases that he had left. So this was left to the head of the pedodontic department, Drex Boyd, and I just bugged him to the place where he finally let me start putting in ideal arches and tying wires and using ligature tying pliers and using ligatures. And so really I got interested in the edgewise mechanism as a senior in dental school.
Now, when did you go to dental school to begin with? What
Indiana?
year did you enter?
I entered in '42.
And you finished?
This was in the war, and finished in '45. So I went, ours was a speed-up program, so I went through dental school in 2 2/3 years.
Now, did you go directly into orthodontics from there?
I had, in my junior year, the very beginning of my junior year, I had hitchhiked to Chicago and had an interview with Brody. So I was admitted to the class of '45 in 1945 because we graduated in August and I was supposed to go there in September of '45. Meanwhile, they wanted us to come back in the service, so I had to put in 2 years of duty in the Navy as a dental officer. I was pretty bent out of shape at the time, but I think it was a marvelous experience for me because I did have some opportunities in the service that I think added to my base, my foundations. And I think I was much better prepared when I went this time. I was then admitted to the class of '47, but by the time now there had been an accumulation of really some good record people, and I was put on as an alternate with, would you believe, Przansky and McGonigal. The three of us were the alternates.
Is that right?
Finally made it in the class. During my tour in the Navy then, I took all my books with me. I completely reviewed every textbook that I had in the 4 years of dental school and those 2 years in the Navy.
Now, part of your coursework, particularly the course that you offer at in your own office facility, stresses anatomy very heavily. Where did that all come from?
I'm not exactly sure. I always liked anatomy. I always liked anatomy and physiology. And I always felt that if you didn't know your anatomy, that you were pretty much lost when it came to discussing the details of function, the details of physiology. So I always felt that anatomy was a basic reference, and that probably osteology was the foremost reference that anyone could have, because if you didn't have that, you didn't have an orientation, and if you didn't have an orientation, you couldn't learn.
Now, how much cephalometrics was used in the program when you entered? Is this something...
At Illinois?
Yeah.
This was in 1947, and at that time, Downs was just still collecting his material, which he published in '48. Mm-hmm. We did get the Downs analysis. The class ahead of me, however, as a reference point, used their cephalometric analysis from physiologic rest position. And of course, by that time, Downs had given that up. Originally, it had been done at Brody's insistence, I think, because of this prevailing thought at that time that everything emanated from rest position, and that was a constant thing, and that's what you had to treat to. And part of my original work discharged that idea altogether.
One of the things that I have seen in the last few years among our own residents here at Michigan is I don't think that they really appreciate Dr. Brody and what he did and where he sort of fit into the whole scheme of orthodontics and orthodontic history. Can you give us a couple minutes on Steve Brody?
I could. And I suppose it started, the first time I heard of Brody was from Dean Crawford. And when he asked me if I was going to go ahead and pursue this, he said, well, there's only one place to go, and that is to Brody at Illinois. I say, why him? He says, well, he's the only one that's going to teach anything. And I thought that was rather strange, that there would, in all of the dental schools in the country, that here's one person. And so naturally, I was interested in an interview with him. And so, as I said, I hitchhiked up there. And the minute that you walk in the presence of Brody, you get the idea that this person is a very sophisticated and knowledgeable person, and one who has this talent of stimulating you and wanting to stimulate you. That first interview, one of the students came in with a patient, and the patient had just been retained. And I looked in the kid's mouth, and it was just beautiful. And Brody said, wouldn't you like to do orthodontics that way? Wouldn't you like to be able to do that? And I said, boy, would I. And this was just a part of Brody. Brody was selected by Angle, of all the students that Angle had, to continue his flame. Before I left Illinois, I had stayed there for 5 years. Brody had me out to his home one night, just me and his wife, Vera. And he said, did I ever read you my letters? And I said, no, I think I've heard you talk about them, but I've never heard them. And he, in his library, then reached up on the top shelf, and in a box labeled letters, he pulled down, and with tears in his eyes, he read the handwritten word of Angle to him, in which he had been chosen to carry on Angle's work. Did you know this?
No, I didn't know that.
And he said that that of all the students he'd had, that Angle had the talent, that Brody had the talent, and that he hoped that he could carry on what the goals were that Angle had had in his career. I sort of wondered why Brody had done that to me, because in Brody's way, maybe he was trying to tell me that maybe I was the next in line to carry on this flame that Angle had.
Do you think you've done that?
Yeah. I think probably, if I could be candid and be objective, I think that probably me more than anybody since Brody has tried to carry the whole feeling of biology and mechanics and tried to tie the two of them together. I think that's been one of my fortes. Brody, staying with Brody, had this particular talent of stimulation. To his students, he made you feel that orthodontics was just about the most important thing that there was that you could do in your life. The students would get so excited that sleep was forgotten. It was just one of those things that it was so motivating to listen to him, and being in that atmosphere, it was just something that was lifting. It was just a whole transition among the students that took place. When I went to Illinois in 1947, I weighed 196 pounds. I went home at Christmas, I weighed 164.
Is that right?
So I'd lost 32 pounds in about 4 months. And my father saw me and he says, "Good God, what you trying to do, kill yourself?" And so that was the kind of conditioning that was there. That was the kind of intensity that was there with the whole affair.
What kind of a teacher was Brody? In other words, what kind of interaction did he have with the students?
I've often said that there are 4 or 5 ways of teaching, and the true seminar way of being a leader of a discussion is probably the #1 effective way of teaching. You teach by asking questions. An intelligent person who knows his subject can know what questions that are going to lead into the next one to ultimately get the message over in the mind that is going to be retained. The nice thing about teaching in this manner is that a thought that comes it belongs to the student. It's nothing that was forced on him. It's something that was an established pathway in his brain. So it is a method of not only teaching, but it's also a method of retention of the information that's there. It becomes highly stimulating. The other part about it was it just wasn't bands and teeth. It was biology, it was geography, it was geology, it was the issues of the day, it was politics, it was religion. It was just about any subject that came along the way. And so it wasn't that you were just trying to learn to be a clinical orthodontist. I always said it was learning to be a man or a woman, an adult thinker. And this was what Brody was about, and this is the grasp that he had on the students that really was prevailing.
You think that there's anybody in orthodontics today, that's present company accepted, that would fall in the same mold or have the same stature that Brody had when you were a student?
I don't think so. I think, as we discussed at lunch today, I think that we're dealing with a brand of a whole society that unfortunately is waiting to be entertained rather than entertaining themselves, that is waiting to be educated rather than educating themselves, that has somehow lost the joy of the pursuit. I don't know exactly all of the social factors that are involved, but it's going to be a rare student that comes along now that's going to catch this flame. They're bound to be there, but I don't know who it would be right now. I think even if many of the people in education today, if we would have a Brody come along, that I think that our social problems are such that he wouldn't dare treat students in the manner that Brody treated them to make the most out of them. Brody had the idea, and I discussed it with him many times, that the very moment that you tell a student that what he does is acceptable, then he's going to become complacent and he's going to fail to grow. That if he thinks he's already there, why should he work any harder? And so it's anytime you make too many compliments, you are killing the incentive, at least at that level of education. Maybe if you have a child that needs some encouragement, some patting on the back and some loving and so forth, as a youngster. But by the time that you reach an age where you should have maturity, I don't think that compliments is going to get ultimately the most out of a student in his career. I really don't believe that. So that's what Brody had, that he got from Angle, because that was Angle's philosophy and teaching also. So look at the impact that Angle and then Brody had, particularly in education.
Who else on the Illinois staff had an impact on your career?
Well, of course, Brody was number one because he was the kingpin and he was the force. When I was there, of course, Bill Downs was the guy that we really looked to for clinical knowledge. He had taken the Tweed course, and he was endowed with the capability clinically, and he had the knowledge, and he was in cephalometrics at that time. And don't forget, we got cephalometrics before it was even published, his analysis. In fact, he was still working on it, and he was adding the last part of it, the Lorentz Sizer to the occlusal plane he was still working with at that time. And so Downs was highly influential. He'd come in on Fridays, and our class would all meet for breakfast. And we had a very close class. And we used to have parties that would match any party you've ever heard of, because we were all intense, and when we relaxed, we really had some great parties, because it was all in fun. We all genuinely, and our class is still very close. The people in it are still very close. It's a genuine love that we have for each other. So Downs was the big, was like a father too.
Who else?
Renfro was on the staff. He was a junior member. He assisted Brody. Al Moore was there for a few months in the beginning before he went to Washington. We did still see the influence of Goldstein and Meyer that were there. Jerry Bosser and Boscher and Bill Bluer were junior members of the staff that stayed on and helped a little bit. But essentially that was the staff. We also had many lectures from Massler. We had open arms when we'd go down to Shower's department in histology. I had a wonderful rapport with the people in anatomy and physiology. I was the person that got Przansky interested in doing his original work in electromyography with the Department of Physical Therapy in the medical school. Ivy was doing a lot of his research at that time, so there was a lot of medical students that we could converse with, that we would meet with in the YMCA and Greek restaurant and so forth that was around the university at that time. So that was an atmosphere.
If you could step back and you could look at Bob Ricketts circa 1947, what would you describe? What were you like?
I was a fun-loving person. I had played football. I had been a dance instructor. I wouldn't say I was a ladies' man. I wouldn't run the other way, but I think I was hungry. I'd come from a farm, and I think that I wanted to make something of myself, because I'd laid out a school a year and worked in steel mills, worked in a radio shop, a radio factory, a Delco radio for General Motor radios, and had gotten a little introduction to electronics, worked with metals, worked in the wire mill, in the steel mill, and I was hungry. I also, underneath, had a tremendous ethic. I wanted to do something for people, and I was highly curious and highly imaginative. And I think I came prepared, because for the 2 years that I was in the Navy, I had literally almost every day studied something, started reading the literature. And when I went to Illinois, I was versed in anatomy from 3 textbooks. And somebody asked me about a particular thing, I'd say, well, which book do you want it from? Because they wouldn't all be the same. And so that's the kind of student I was when I got there.
What, you told me the other day or yesterday that you're probably working harder now than you have in any time in your life.
Yeah.
And so you've had a very long history of being an overachiever
Yeah.
in a good sense.
Yeah.
What drives you? What makes you go? What is it that made you do all the things that you've done in your career?
Well, I keep referring back to the work of Ardrey. There are three things that motivate people, that give them their drive. The first is identity. And to understand the word identity, you have to understand its antithesis, which is anonymity. In other words, I have to keep convincing myself that I'm somebody, maybe, looking, again, candidly. Certainly, it's not that I have a bad opinion of myself that I'm trying to build, but I still feel that I have a potential that I haven't filled yet. That's what keeps me going. I still feel that my job isn't done. I still feel that there's more to learn and more of a contribution that Robert M. Ricketts has to make. And I think that's what keeps me going. The second thing, as Ardrey explained, is stimulation. And the antithesis of that is boredom. So to understand the second most overwhelming drive that we have, and that is stimulating, or stimulation. And I find the research, and I find these things, I'm highly curious about them, and they're stimulating. So it's of interest to me, and I want to learn more. Mm-hmm. And the pursuit of knowledge is just about as much of a pursuit as anything you could ever ask for in a human life. Now, the third motivation that we have is security. That's the lowest in the hierarchy. And the antithesis to that is anxiety. I don't think that security is one thing that I've been stimulated by for a long time. So that I'd have to say that the thing that keeps me going is the fact that I still feel that I haven't accomplished all the goals that I'm potential of having. That's number one. The second thing is that, God, I'm having fun.
Nobody can argue with that.
Yeah,
for sure.
It's just wonderful to travel the way I have around the world, all around the world, to have the respect of all the people that I've met and the real love and friendships that I've made through orthodontics. I just owe it a great deal, and I just think that it's a marvelous thing. And I suppose those two things. People have asked me before, and I say the two things that I believe that I have is, number one, I keep developing my intellectual background. And that then, on top of the curiosity that I have, I think has fitted me to do the things that I've done, and the motivation then and the platform to continue.
Now, we're sitting here today in a very formal university setting. And did you expect that when you left Illinois that you would end up basically doing you're almost in a private institution of your own creation rather than a public institution? Yeah. Was that part of the plan, or is it just the way your life went after Illinois? Was that something that was planned out, or was it just serendipitous?
It wasn't planned at all. As you know, when I left Illinois, I had developed the techniques with laminography. We had the visualization of the joint, and I'd worked out techniques where we could get a better understanding of what orthodontics was about and what growth was about in those years. And on the basis of those early experiences then, I worked out a technique of projecting the growth and projecting the treatment changes simultaneously, and drawing up a paper plan for a patient's plan, and then working out the anchorages to achieve those goals that were put out there, and then monitoring back and forth to see what mechanics would produce to achieve that result. All of that had been worked out. In addition to that, I had naturally a farm boy, experiences with lathes. When I was 12 years old, I would crawl in a thrashing machine, and because I was so small I could get in it, fix it for my dad. And that was when I was 12. I pick up a piece of wood and carve a tooth on it. So I had this kind of ability mechanically and an imagination along with it. So here I was, even before I left Illinois, I was making innovations. And in fact, Brody came to me one time and asked me, please, if I wouldn't mind, I was no longer wanted to supervise cases in the clinic. And the reason for it was that I was changing technique.
Oh, is that right?
Oh, yeah. And he finally said, why don't you just take all of the crud that we have and finish it up for us? And if you will, then you give a course to the graduate students on occlusion and TMJ from its total aspect. So I was then asked not to supervise cases on a clinic basis. And I said, that's fine with me because I want to be free to do the things I want to do anyway.
Why did you leave Illinois, period? I mean, what was the reason that you went to California?
Number one, I was still under Brody's thumb. Even when I would publish, he would go over my papers, and there would always be a little bit of Brody in my work. I felt that I didn't have the freedom that I wanted. I didn't believe, while he said I had complete academic freedom in an institution, I felt that I was still pretty much obliged to cooperate with the status of the whole thing. That's number one. Number two, I married a California woman, and I had relatives in California, and I felt that there were opportunities there that I wouldn't have where I was. I knew that Steiner and Nance and Tweed were in the Southern California Orthodontic Angle Society, and I know that there was a great deal of progressive thought that was going on out there, and I wanted to be a part of it. I felt also that I had freedom to do things out there that maybe even in the Midwest I would not have. So that's what took me to California, that combination of factors. Brody did his best to try to talk me out of it. In fact, in a letter he wrote me, he says, I think California is a good place for you to go if your brains are dead. But when I went out there, I found out there's more PhDs per capita in California than any other state in the Union.
There's almost more of anything in California than any other state of the Union.
So when I started practice and started doing the things that I was doing, I was still asked to go to speak. I got on the circuit starting in 1950, getting up to explain my research and what the findings were and imagination things that we were doing and where we thought things were leading. And it wasn't long before I began to have visitors. Entire study clubs would come and be with me in my practice for a day. And so I recognized that people wanted to learn and people needed to learn. Now, the real stimulation for the formation of extra courses, who do you think was responsible for it?
I don't know.
Now, you're sitting down.
Yeah.
Bob Moyer.
No.
Yes.
Really?
Bob Moyer visited me in California and said, Rick, we've got to get you back. Some of the things you're doing are just marvelous. You know how exciting Bob is. And he just thought it was wonderful. And I have to give Bob a lot of credit because he was one of the very few people who encouraged me. Most of the people, you have to understand, in this time and age, when many of these thoughts had come and many of these things were being done, that I was overriding all the criticism all the time. Everywhere I would go, I would be in fights. I mean, I've given lectures and walked out of my lecture and walked down the hall, and everybody would turn their back so they wouldn't have to look me in the eye, say that it was good or bad or indifferent.
Now,
but Bob stimulated me to.
When was this? What years are you talking about?
We're talking now about 1962.
Okay.
He came back and started talking about the things that I was doing, and he said, we've got to get your stuff in the University of Michigan. And he says, I've got a man back there that's just the guy that I want to get your work. His name is Bob Aldrich. And so I came in at Bob's invitation and put, I think, a 2.5-day course on for the alumni at Michigan, right here. And after the third day, I went to Bob Aldrich's home, and he wanted me to put a course on. It wasn't the first invitation I'd had, but he said, "Now you've got to. We like what you have, but we know that we can't get it just in passing through here. We want to come out. We want to pay you. We want you to give us an organized course. Please, will you do it?" And I says, "No, I'm not sure I want to get into this. I'm still researching. I still have my things that I'm working on, and I'm not sure that I want to take this amount of time." Finally, after an hour of him talking to me, Ransom Westover was also with him, Bill Klaus,
yes,
and Bill Heisel. And so that group there in Aldrich's home that night in about 1962 or 63, I agreed to put on a course for them. So I then made some phone calls to some other people who had wanted to take a course. So in February of 1964, I put on the first postgraduate advanced orthodontic seminar, and that's how it started.
Well, you know, Bob Aldrich now still practices in Ann Arbor, and he's told me many times about his being in your first course.
Yeah.
So that's great.
Yeah.
Now, you mentioned that you were a source of controversy.
Yeah.
And having personally also been in that spot occasionally,
Yeah.
I can relate to that. What would you say when you came out of Illinois in, let's say, the early 1950s?
52.
Okay. What was the existing or pervasive paradigms that were existing in orthodontics? And where did you deviate? I mean, I know from now where you are today, but I'm not really clear as to what was the state of the art and then what was the new art that came out of it.
Okay. As you know, in the 30s, well, let's put it in the 20s, the edgewise system was born out of the 1920s. It precipitated in 28 and 29, and Angle died in 30. His students took over, and they had this marvelous mechanism which you could control all the teeth, band all the teeth, get in, and you could... So the theory was in the beginning that you should be able to treat the entire malocclusion in the time that it took to treat the slowest responding tooth, which was the molar. If you could, with intermaxillary traction, correct the molar relationship in 3 months, then you should be able to do the whole thing in 3 months. Now that sounds incredible, but in 1928, Brody published an article on the rapid treatment of Class II Division I, and would you believe he was advocating 3 months treatment, or even less.
Wow.
Now he said we shouldn't say that that you could get all cases treated in that time any more than you could say that you could treat all cases in 10 months with the ribbon appliance. So they were treating 10 months with the ribbon appliance for a case. Now that's incredible in terms of what we do today. I mean, I would no longer think of trying to do that, achieving that, because that's unbiologic as can be. Well, in the result of that, now don't forget that Ray Begg also was one of those people trained in this edgewise philosophy, the primary edgewise philosophy. Even when I was a student, we took 6 months to set up the anchorage, so to speak, get each arch individualized, 3 months with intermaxillary elastics. We were finished in 9 months. Even when I was in school in 47. Our goal was to get our cases treated. Ours was the first class that was beyond 1 year in orthodontic graduate work. We went 18 months.
Okay,
you see?
All right, now that you're telling me some stuff that I guess maybe being slightly younger than you, I haven't really heard that much. Let's go back over that again.
Okay.
You're telling me, and we heard Art Lewis talk about his 1 year program.
That's right.
That you'd set up a case for 6 months. This is presumably a non-extraction case, right?
Yeah, well, under Brody,
okay,
we learned non-extraction,
okay.
and I called that the old primary edgewise. Now I had secondary edgewise, and then tertiary edgewise, and then bioprogressive.
Okay.
So I went along that chain in the development of what we're doing today.
Now, how did a change in molar relationship in 3 months occur?
With intermaxillary traction.
But it was strictly tooth movement? I mean,
Strictly tooth movement.
how many ounces or pounds or whatever?
Well, they had, when I went to school, we had the old rubber elastics, the gum rubber, and the patient changed them every day because they got soggy. And we applied second-order bends, the tipping back of the upper molar, progressive tips, and even to the canine, and this is supposed to be activated by an intruding force against the upper incisor. And don't forget, it was only in 1938 that they did the first analysis of treated cases with that appliance. And you see that's what entered all of these limitations into orthodontics, was the edgewise appliance, in my opinion. Well, it's not just my opinion, it's pretty good fact now that this is the way things are going. How much could you intrude teeth in 3 months with the continuous arch? How much could you enjoy growth? How could you do anything other than move teeth in 3 months? Now, if you're going to open a bite by mandibular rotation and you're going to treat a case by displacing the lower arch forward, you're going to end up with a double protrusion. It's not going to look good. It's not going to retain well, and it's going to end up with a face full of teeth. Well, you come along now, and that's what Tweed was trained in. If it wasn't 3 months, then even in the secondary edgewise that I got.
Now, what was the difference between the primary edgewise
The
and
primary edgewise was that you put intermaxillary elastics on the day you started the case.
Okay.
So you separate, put the whole appliance, adapt an 022-028 in an 028 bracket. And every adjustment,
Gold wire.
Gold wire.
Okay.
And every adjustment, you took it out. You saw the patient every week to every 2 weeks. It wasn't any of this month visits. It was a minimum of 2 weeks. So you were in there moving teeth as rapidly as as the patient could tolerate, really. And you put stops on the molar tubes on the wire, and then put a washer in to advance the wire to make more space. If the teeth were crowded, you continued to tie them in. And any time that you have a complete unit, the one that's going to do the moving is the weakest unit in that whole. It's like a stave around a barrel. It's going to have the same pressure everywhere on that stave. Well, the arch wire is the same. So any time that you had to expand, it became synonymous with forward movement of the lower incisor because that was the weakest tooth. And it would be the one that would get displaced. So with that technique, any time that an edgewise orthodontist thought of expansion, it was immediately forward movement of the lower incisor. So that would put stress at once. Now you put intermaxillary elastics on, and at that time you were busy expanding the arch, so you pushed the molars here, you pushed the molars out of root position, and you put intermaxillary elastics on. There was nothing to hold them, so the lower arch blew, and you dumped the occlusal plane. Now, a number of people saw that, so when Tweed started showing that he had treated these patients this way, gone in and taken out 4 teeth and brought the teeth back, taking another course and being heroic, treating them all at his own expense, he became a hero. Because a lot of people had seen the same thing, so they saw this vehicle then, so they can have the edgewise appliance, have the technique, take out 4 teeth, treat a patient, and achieve their goals. So this, in my opinion, was the evolution of the whole era, which we call the doctrine of limitations. And that's what I saw. That's what I experienced. Don't forget, I came into orthodontics in '47. That was the year that Hayes Nance wrote his article on limitations of orthodontics, which incidentally was written by Wendell Wiley. Did you know that?
No.
It was Hayes' material, but it was written by Wendell Wiley. Why his name wasn't on, I don't know. But also, that was the same time, the next year, that Strang wrote the article on the fallacy of expansion in orthodontics. Now, here's a guy who wrote the original work on expansion, wrote the book in 1935 on edgewise technique, and suddenly now, in the period of 12 years, he had completely gone to the other side, where he was praising Tweed and that you could not really expand cases. And so this was the era that I came into. Now I come along with laminography, with growth forecasting, and with my experience with Downs, with Brody, and on my own, come in with this technique, and I had to cross then the Tweed group in Southern California, which was probably the strongest any place, as it was in Southern California, with Nance and Keaty and Steiner and Chuck and all of these people that were present there when I went in, including Tweed, was in that society. So I came into that hotbed at that time. Now, when I started opposing extraction, when I started putting in canine rises, because at that time you were supposed to take your cuspids out and put them all in group function. Mm-hmm. So I got into problems in occlusion. I got in problems because everybody was in this tie-back business of very vigorous forces. So when I started talking about lighter forces, and then later when I went into progressive banding of cases rather than getting all of the bands on at once, moving teeth out of the way by moving teeth, intruding teeth and so forth rather than by separators, that was strange to them. So I had that problem. Nobody believed that you could get a condyle back too far in those years. Nobody. One of the best known clinicians there was called me up one time. He says, "Rick, I think you're all wrong in this." I said, "Well, wrong in what?" He says, "I've never seen a condyle back too far."
I think he's
what am I going to say?
Yeah.
So you put those together, and then the idea that I could predict, the idea that I could set up a case, call my shots, and then execute. It was, don't forget, when I went to California, there was only 5 cephalometers in the state. And 2 of those were in institutions. And nobody was using cephalometrics at that time. They were still in, I remember one of my colleagues over a beer one time, he says, well, tell me what you can really see with cephalometrics that we can't get with our models and our photographs. So that was the climate that was prevailed in 1952 when I went to California. They were grinding teeth.
Tell me about the interaction between Brody and Tweed.
He was no longer putting on intermaxillary elastics at the start. He was beginning to think in terms of taking longer to treat patients, and having taken his practice for 2 summers when he was gone on vacation, I knew what he was doing, and he didn't even treat his cases as fast in his practice as we did at school. So he had to treat cases faster at the school for the technical aspects of getting students exposed. So he extracted in his own practice, and my judgment was, in seeing his practice, it was about 15%. The technique that he used for extraction when he did so was to go in and level the arches, as we had done typically, take out the bicuspids and then nothing but tiebacks. Mm-hmm. And as you and I both know, that's going to be a way of displacing the lower molars forward rather rapidly, but that's the way a lot of extraction was done, even with Tweed, with these vigorous forces, before he went to class 3 elastics. So this was what was happening in the 30s. Angle had gone through, because when Angle came into orthodontics, the pendulum was all the way on the other side toward extraction. Mm-hmm. All class 2s were treated by extraction of upper bicuspids, moving the upper incisors back over the lowers. All class 3s were treated with taking out lower bicuspids and bringing them in under the uppers. And that's the status of orthodontics when Angle came in. Now, Angle then found along about, I guess, 1895 or 1898 or somewhere in there, just before the turn of the century, from Baker. He called it Baker Anchorage. And he found that intermaxillary elastics could correct a whole arch. Now, nobody would think that just a light, little, thin intermaxillary elastic would be strong enough to move a whole arch of teeth. Mm-hmm. But when that was discovered, then they they began to employ it, and Angle saw that now as a vehicle where he would not any longer have to extract teeth. He also had the idea that with treatment, particularly at the young age, and this is something that a lot of people don't understand, that Angle advocated very early treatment. I mean, even in 1926, he did the baby ribbon, which was designed for the deciduous teeth. Did you know that?
Nope.
1924. That was the interim between, actually, the edgewise, the ribbon appliance, and the edgewise. He didn't go from ribbon to edgewise in one jump. There was an interim appliance called the baby ribbon. Most people don't know about it. Atkinson helped him work it out. That's where they had their clash. And then Atkinson went to Universal, and Angle went to edgewise.
Oh, I see.
That's how the clash occurred, and both of them got patents the same year in 1928. Did you know that?
No.
That's what happened. So this was the status of orthodontics when I went to California in 1952. So coming in at that time, they had not yet started using extraoral traction as a rule. They were following Tweed, and this is just in the beginnings of extraoral traction when they first went there. So that was the status.
Now, when did the term bioprogressive come into existence?
Okay. By 1958, we had started with class 2s with second order bends, and by the time that I started my practice in 52, with the studies that I had done, I found that was nonsense. In theory, it would work, but practically it didn't. It just couldn't be controlled the way that it was anticipated to be controlled. And we ended up with this displacement. It was locking the upper arch more than anything else. It was locking it so that it couldn't respond. I have to give Chet Wright in South Bend, Indiana, a great deal of credit for my whole career.
Why is that?
Number one, I always said, people ask me who is the greatest orthodontist that I have seen. I said, well, there's two men that I always felt that were the tops. If it was an extraction case, it would be Hayes Nance. He did more attention to detail and extraction than anybody I ever saw, even today. The guy that was the best technician without extraction was Chet Wright in South Bend. He went to Michigan, in fact. Did you know that?
No, but that's
He
always
took
nice.
the Dewey course,
Yeah.
too. But the first time I saw him work was he was using sliding hooks on steel wires. And he later came to use 21 steel wires so he could slide the teeth down. Well, my studies indicated that even this was going to tip the whole occlusal plane because there's a force, as long as you had that with the incisors banded and engaged, the force is going to do this to the upper arch and it's going to extrude the upper incisors. So one day I had these arches in, I just went in and cut the wire in here. I said, let's see what happens then if I leave these up here and bow this side and put intermaxillary elastics just off of the buccal segments. What's going to happen? So one day, clip, clip. Next patient, clip, clip. Next one, clip, clip. So I had a whole series of patients then, and I was taking buccal segments back independently. Well, that gave rise then to understanding then the forces that were operating through this part of the arch. The next thing that I ran into was this business of separation, which always bothered me.
Separation meaning what?
Separating all the teeth.
Oh, okay.
And placing of an appliance. So I started putting molar bands on and only canines here, molars here and canines here. And I started moving teeth, intruding canines with this, and I saw the molar back up. And so I started banding teeth in a progressive way. That's where the word progressive came from. So I had been doing this by started doing it in 52. And then by 1955, I had started using preform bands. And by 1958, I had worked out all of the preform bands. And my typodont for the American board in 1958 was the first one that was all done in preform bands, steel preform. So with all these bands that I had, and pre-mounting of the tubes rather than just the brackets, working it out to the level of the margin of the band rather than the height of the bracket. And all this, I had a technique which was highly efficient. I could band up a case. I'd proven it with stopwatch. 15 minutes of my time for a full mouth. I mean, it's incredible.
How long would it take before to do that?
2 hours.
2 hours.
Yeah, so that's 1/8 the time that we'd been using before.
Do you think that if bonding had been available when you started, that
I'd still been progressive, because the results of that, if I hadn't have gone through this technique and all of that, I wouldn't have understood what you can do with a molar from 4 lower incisors. That happened in '63. The utility arch was born as a result of experimental orthodontics and following it with cephalometrics. Of course, in those days, I did all my own head films, and I was racing. I was taking them all the time. So now putting that all together, in 1958, I was a guest speaker at the European Orthodontic Society and a guest of Bjork. And a lot of people asked me what technique I was using. And I said, well, edgewise. Well, I realized that the image that they had of edgewise was tweed edgewise, and that's all. They didn't understand the versatility of multiple brackets on teeth and the versatility you had with lighter forces. And I realized at that time that I had to have a new label. So in the beginning, I called it a light square technique, and it wasn't always light and it wasn't always square. And I was using progressive. So in 1966, I had one of my classes, one of my early classes, and I said, well, you've all seen what I'm doing here, and you know that it's different. It's not what we have seen as traditional edgewise, which was the primary, the secondary, or the tertiary, which was tweed edgewise. And I said, what are we going to call this? I've called it a progressive technique. And that was the class that Tom Christie was in. And it was a very alert class. That group was one of the most outstanding I've had in 1966. And we were meeting in my home and sitting around on the floor after dinner and discussing the course and things, as we do. We used to call it the Last Supper. And so they said, well, we've been thinking about this, and we think that the word biology should be represented. So right on the spot, we said bioprogressive, and looked around the room. Everybody agreed. So that's when the word bioprogressive was born.
Okay, we're just about running out of time on this segment. Do you have any other, along the things that we've talked about, any other comments you want to make?
About these developments?
Yeah.
Well, I think that maybe about 2 years ago, I had my family at I guess it was Sun Valley, Idaho, for vacation, Christmas vacation. And I was babysitting, and everybody else was out on the slopes, and I was sitting there. And it had to be longer than 2 years, had to be a few years back. And I started to put together all the changes that I had made in the sequence going back from the start of my experiences in orthodontics, a change in philosophy or a change in technique. And I started to list them. And it grew to a list of 278.
Okay.
So I have shifted somehow in technique or philosophy 278 times in this 40 years.
So the Ricketts of 1966 is not the Ricketts of 1987?
Not at all. And people that took a course from me 15 years ago or 10 years ago, even 2 years ago, it's changed. It's been a progressive change all the way through. And as new ideas come along, a lot of times I've made an investment in an old idea but you have to give it up. You can't stand on where you are if you're going to proceed. You can't stand still.
Okay, thank you. In the continuation of our interview, I know that you were requested, I think in 1965, by Bert Krause and Dick Riddell to submit an article to Vistas of Orthodontics. You want to talk a little bit about that? Because I think you said to me before that that sort of gives you a state-of-the-art of orthodontics at that time.
Well, I think that I've referred to that article because it was a requested article where I had to, well, I actually wrote 2 articles. First of all was a phone call, I guess, or letter from Bert, who was a good friend and one that I always admired. And he had asked me to write a paper for testimony for Al Moore. And of course, I'd known Al for many years and respected him. I said, well, I'd be glad to. What subject? Well, do it on clinical research. So I said, okay. So for about 3 or 4 months then, I began to research and all of the aspects of what entailed with clinical research in orthodontics. And so I put together, I think, an article of about 50 or 60 pages with 88 references. I remember that. And I submitted it, and I was pretty proud of it. They said, well, this is a good article, but it isn't what we want. What we would like is specifically the clinical research that you have done, particularly in laminography and cephalometrics, and the work that you have done to date in orthodontics, in diagnosis and so forth. So I hitched up my belt and said, okay, I'll do it again. So I submitted this article, and that was in 1965, maybe late 64. And it's rather interesting that that is the same year that I started the advanced courses. Mm-hmm. So it pretty well represents the status of thinking that prevailed in that year, just when I started the advanced courses. In that article, I'd also classified lips, and I'd classified the 3 different types of tongue thrust that we were dealing with in those years, and pretty much the status of the joint and pretty much the status of growth forecasting and all of that. So anybody that wants to go back and see the status of orthodontics in 1965, get out that 20 years ago now, almost, or a little bit more, of what was taking place at that time and the level of our thinking.
What were the key issues?
Mostly cephalometrics. By now we had begun to feel that there was something about the environment that we could control rather than treating to it. Open bites were a big problem, always have been. Class 3s with low tongues and cross bites. Relapse of open bite and cross bites are the #1 things that we have to deal with in orthodontics. So we were addressing those tough situations, plus forecasting. And some of the techniques of breaking up the arch and so forth were, I had come into at that time, and so that pretty much represented what I was talking about at that time.
Now, in 1968, you published a paper on, I guess, to put it simplistically, all those things that you were taught you couldn't do that you can do.
Okay.
How about going through some of those for me?
Well, let me give you a little bit of background for that paper in the first place. In 1967, I took my family and went to Europe. My wife at that time and 2 daughters preceded me, and they spent 3 months in Europe. I rented the home out and had my son in a camp, and so I lived in Riviera Country Club and rented our home out, which wasn't too bad. No. And I was supposed to go over there, and I went for 2 weeks on vacation, and then I started circling and lecturing. I had gone to Scandinavia, and I put on a course in Spain, and I think in France. Then I was to end up that lecture with an address in London, just an evening meeting in London. And I wondered what I was going to say in London when I got there, because I had already experienced several conflicts with people in England who were really entrenched in this doctrine of limitations. And they, so much to the place where many people wouldn't even try to treat the lower arch, as you know.
The doctrine of limitations coming from Nance's article.
Well, they were using that as a vehicle. But somehow or another, with the scheme that they had there,
What do you mean, scheme?
The social scheme.
Oh, okay. You mean National Health Service?
The National Health
Okay.
Service, they called the scheme.
Yeah.
And I remember at that visit, or maybe before, I don't know, that I knew Jack Tully very well, was entertained in his home and so forth, and went in and saw the cases that he had. And so I went there with him, and I had seen the cases. And he says, we went to have tea. We were there for about an hour and a half, and it was time for tea in London. You know?
Yeah, right.
So we went back, and he says, well, what do you think? I said, what do you mean, what do I think? What do you think of our treatment? And of course, I was in shock. And I said, well, I hated to say it, but in my mind, I thought there were some cases that didn't look much better than they were when they started. And I said, well, in my opinion, you're just ready now. You've done your primary treatment. Now you're ready to finish the case. And that was as much as they could offer the patient. And the irony to me was that they had used all of the knowledge that was in orthodontics out there to justify that approach, that it was as good as anything else you could do. Well, of course, this I opposed. So I knew that they were in this whole philosophy that you couldn't do this, you couldn't do that, and everything. So it came from that lecture in London. While on my trip, I had gone through the Greek islands, and I had visited Ephesus. And I had seen all of the crumbling pillars, and I had stood in the amphitheater where Paul had addressed the Ephesians.
Mm-hmm.
And it was one of the greatest experiences in my life, to sit there or stand there in his place and realize that this is all history, and that this abandoned town had really still was there, as it was in the beginning. So when I got there at London, I labeled my lecture "The Crumbling Pillars of Orthodontics." Have you ever heard it?
Yeah, I knew that. I've
Yeah.
heard you say that, but I didn't know the background.
So that's when I started putting this list of things together that I could no longer believe. That's what started it. That was in the summer, and that fall then I addressed the Angle Society in New Orleans. They had the national meeting,
Mm-hmm.
and I was asked to be on the program. So I enlarged that talk, and I labeled it at that time Public and Professional Problems in Orthodontics, because at that time we were beginning to see that there was a lot of problems in orthodontics with general practitioners. And it was my feeling that one of the things that we should do is to become stronger and unite in our own knowledge and in our own philosophy, because there was a lot of different people out there. The Crozat craze that was taking over at that time, the number of general practitioners who were experimenting in orthodontics was just now starting, and this was 20 years ago.
Mm-hmm.
So I said, well, we should get our act together. This was a plea to get our act together. And so I started it out by listing all of these different things that I had been taught that I could no longer trust, and that I couldn't believe, that I could no longer use this as the bedrock of truths
Mm-hmm.
that I was told that it was. And it started out with, one thing was the constancy of the pattern.
I mean, the Brody type.
Yeah, the Brody type constancy of the pattern. That, you think about it for a minute, if you can't do anything skeletally, then what are you left with? You're left adjusting the teeth to the skeleton, and that's, to get teeth adjusted, then that's that was one of the things that added to this whole idea of extraction, that you just shifted teeth around within the confines of what you're working with. You couldn't intrude teeth. You couldn't move an upper molar distally.
I can remember having discussions in my own orthodontic program, of which our faculty in 1966 were arguing that exact point.
That's right. That's right. You dare not expand. All expansion is going to move the lower incisor forward. You dare never move the lower incisor forward. You couldn't change the oral environment. You see? It went on to 24 things, and it later grew to 30 things that you couldn't do.
Can you remember any other ones?
Well, let's, the main ones turned out to be that we could condense them down to about 7 of them. You couldn't use intermaxillary elastics without moving the lower arch forward. There was no such thing as cortical anchorage. You couldn't use muscle anchorage. You treated to the muscle rather than using the muscle. Mm-hmm. You couldn't widen the palate. Extra oral traction. You couldn't do anything orthopedically. Mm-hmm. You couldn't predict growth. You wouldn't, you may rotate the mandible open, but it was always going to recover. And how many is that? You begin to see what I'm talking about. Go through the list and then add a few more that we added a few years later. So we had these really down to about seven things that you couldn't do things orthopedically, you couldn't intrude teeth, you couldn't move the molar back, and you couldn't change the environment. You couldn't predict growth, and you couldn't call your shots. You couldn't predict anchorage, and all of these kind of things. So on the basis of that, I made recommendations to the profession, which I'll be talking about tonight a little bit. And that was 1968 when that was published. Mm-hmm. So it took a year from 67 to 68 to, and I remember working with Art Lewis at that time on that paper. Mm-hmm. And he said it was too much for one paper, so we broke it in 2 parts. So it's actually a 2-part paper, 68 and 69, and maybe all in 68, I forget.
What do you think are your, let's take those pillars, mm-hmm. and let's look at the treatment aspect of things that you do today or 20 years ago that you were taught you couldn't do. Now clearly utility arches are one of the things that you would be talking about with the intrusion of teeth. What other, including that, what other specific treatment? Let's
start out maybe with how I discovered them in the first place. I started setting up cases in 1950 for surgery and for orthodontics. The first surgical VTO I did was in 1950. Mm-hmm. So the same theory applied to surgical cases, that the only difference was now is putting growth and teeth and physiologic anticipations mm-hmm. with the thing. Once we knew that this was the likely result of a therapy, and we can take that right into our removable appliances today, because now that with the differences in behavior, we can anticipate those kind of things. So to say that all treatment is going to give the same result and that the teeth don't know which appliance is on is absolute folly. So let's go back then with maybe the real arresting changes that we made and how we came to them. And I suppose the first one would deal with the fact that we begin to see things orthopedically taking place. And I think that probably set me off more than anything.
And you're talking mostly extraoral traction here.
Yeah, yeah. One of the other things that I had to say was the rest position of the mandible. You know, we used to say that you couldn't change rest mm-hmm. position, it was unchangeable and all that. So that would go with that 24, yeah. 28 things too about the rest position and dealing with the joint and a few other things. So there's a lot of those little mm-hmm. things that were wrapped up in there. That you always had to have CO and CR together and all that. Terminal hinge, really, at that time. Mm-hmm. So I kind of put those things in there, too. And I'd set up these cases on the basis of my experience with treated cases at the university. And now I found out it didn't work. I was making mistakes. My treatment was beating the prediction all over the place. I'm not talking about a millimeter, I'm talking about a quarter of an inch. So this was no longer anything. And of course I was told that the maxilla was immutable, that you couldn't do this. I was told that that these things wouldn't take place. So having discovered that, having also had to oppose the ideas of a constant physiologic rest position, that you couldn't intrude teeth, that you couldn't move an upper molar back. It's unthinkable that you could move a lower molar back. I suppose that then was the basis for the controversies that started. So that's what started. Now, what was your question again?
Well, I was trying to look at the specific treatment modalities that you have instituted.
Okay. Well, the one thing then, of course, when we came out was the fact that you needed to treat patients at a young age. And in my opinion, if you get the patient at these ages by this treatment and other modalities, you've saved them from surgery, because there's an awful lot of a tremendous surgical movement in the country today. I don't know whether you know that. Well, I'm sure you do. The depth of it that's out there. There's almost as many surgeons being trained today as there are orthodontists. And who are they going to operate on? They're going to operate on orthodontic failures. That's what's taking place.
Now, when you say early treatment, what do you mean?
I'm talking about even in the deciduous dentition. That to me is early treatment. It's not early until it gets in the deciduous dentition. You can look at your own daughter's cast there if you don't believe in early intervention.
Sure.
I mean, she's been widened that far, and she doesn't look like she's expanded. In fact, she looks like she needs more to me. And she does. She's got one. So, but you're not going to get that if you wait until the patient is completely grown. These possibilities do not exist with particularly females at puberty. They're already over the hump, and you're not going to get some of these things done. You can still treat them, but you don't treat them the same way. So this took me into early treatment, what I call the prevention stage, preventing the malocclusion from involving the permanent teeth by treating them in the deciduous dentition. That's what we mean by prevention. Interceptive then, intercepting the transition from the deciduous to the mixed dentition, and the mixed dentition into the permanent dentition. That whole broad gamut is interceptive orthodontics. Then corrective, and then finally, when all growth is, let's put effective growth has ceased, we then go into what we call rehabilitative orthodontics and rehabilitative techniques.
Now, when you talk about interceptive treatment, what specific treatment modalities are you dealing with?
First of all, you have to think of a treatment as primary, not finishing technique. You're not going to finish the case at this time. So you're talking about intercepting the development of the malocclusion, altering skeletally, changing the environment, setting a stage then for normal development of the permanent side teeth or the incisors if it's a deciduous case. So this is what I'm talking about now. Any modality that will do that. So if the dysplasia is in the upper arch, you have extraoral traction. And as you know, I have 28 mistakes that people made with extraoral traction, 28 of them.
For example?
Simply where you put the tubes on the molars. The construction of the extraoral headgear, whether you use a biplate with it or not. How much you use it, how much force is on it. Whether or not you have the upper teeth banded at the same time, which you shouldn't. The adjustment in it on a daily basis. The type of case that you use to select it, to use it. The possibilities and probabilities of the growth pattern and so forth. And that came out to be 22 mistakes that people had made in the past. If they didn't do headgear in the right way, they're going to get in trouble with it, and they did, didn't they?
Yeah.
And people made such gross errors with it. In my opinion, today, in my experience, with proper use of a headgear, I can stimulate the mandible to grow.
How do you do that?
By releasing the posterior support, by taking the condyle away from the eminence and letting the condyle grow vertically. That will take advantage of the archeal growth, and the chin will swing out under.
Do you find that by doing expansion in the upper, that you set up a template of the teeth so that in fact the mandible has to move a little bit more forward anyway?
I think that you free it for its freedom of movement, which I think in deep bites it has restriction. I don't think in terms of AP anymore in growth of the mandible as much as I do in the vertical, not in the chin, but in the ramus.
Mm-hmm.
And I think it's because, and I should talk to you about this, because you've looked histologically at as many joints as anybody I know. But my impression is that in the human, the bulk of the cartilage is on the anterior superior slope.
Well, on the superior
Yeah,
part of it.
yeah, and that it's growing superiorly. If you look at the back end of the condyle, a lot of times you've got resorption taking place.
Well, I think Bjork has shown that somebody that has a horizontal growing mandible will be growing vertically at the condyle,
That's
which I
right.
must admit is a concept that I don't think everybody totally understands.
That's one of the first things that I had to overcome also. That if you go back to my 52 paper, which was my prize-winning paper, the fact that as we analyzed the patients under treatment in the previous 5 years, that when we got backward growth of the condyle, that the chin was dropping down, and that cases in which the condyle was growing upward and forward, or the mandible was becoming more acute, were the patients in which the chin was growing forward.
Mm-hmm.
Therefore, if you really wanted to change a patient in their pattern, that it made sense then that you wanted to get the vertical growth so that you could get the chin coming out underneath the maxilla in class 2s. The opposing of that is the opening that takes place in class 3s while the chin's still growing forward. Those patients are developing overclosure.
I know when I took your course in 1974, one of the techniques that you advocated at that time was the quad helix appliance as an interceptive device.
Mm-hmm.
You want to discuss that a little bit?
Well, this started with the old W appliance. When I was at Illinois, Brody came to me my second year and asked me if I would be the orthodontist for the cleft palate program at the Crippled Children's Service at the State of Illinois. I was a part of the original cleft palate team with Kep Baker and Przansky and the ear, nose, and throat people and all that. He also said, do what you can, anything you can do, to prevent the mutilation that the surgeons are doing to these cleft palate children. And he says, you have absolute freedom to do anything you want to do. So I began to look around for techniques, and I consulted at that time Bill Adams at Indiana.
Mm-hmm.
And he was original. He showed me the original Pollock W. I didn't know that Pollock had designed it. I didn't know where it came from.
Mm-hmm.
Pollock later told me that he did and wrote a paper on it, in which was entitled History Repeats Itself. Do you remember that paper?
Yeah, a long time ago.
So he took credit for the W appliance. Well, I didn't care who did it. I just didn't know that he'd done it. So we began to put in this W appliance, and I began to see that that was my first inkling that we could do more than move teeth, because I was seeing in frontal sections, laminographs, tomograms, I could see that we were widening the jaws.
Mm-hmm.
And so that was done in 40 thousandths gold, and I was following these later with frontal head films on a routine basis. And I began to find then that the palate was widening in patients where I weren't cleft.
Mm-hmm.
And so I could see that, that this was a possibility. I began then to modify that with a loop on either side to give it more range, so that I wouldn't have to make adjustments on it so much, because in the beginning I'd take it out, cement it, adjust it, take it out, cement it. So I was taking it off and readjusting and re-cementing. And I wanted something that I could adjust intraorally. So I started out with a loop here, which gave me more range, and then one day I started using alloy wire. It was too heavy, too much force, hurt the teeth, and so I reduced it to 38 thousandths blue alloy. And at that time then I said, well, why don't we experiment with another loop? So I put that was 4 loops in it, and I would compress it, and I measured it, and I found out that I could put 600 grams of force on it, which was enough to split a pallet. The other thing that I didn't like about the other techniques was that if you have a rotated tooth forward, that you expand it and you still have the rotation after you get it expanded. So if I could get something then that would widen the palate, that would rotate the molars, that would open up the airway, and give rise to space for lingually displaced upper laterals, I'd haven't had a good appliance. So that's the birth of the quad helix.
Now, what kind of cases do you use a quad helix today?
Oh, God, it just seems like I use it a lot. And since that time, of course, Wilson with his technique, and a lot of people like it. I don't. I would still prefer to solder it. But we have the removable quad helix now that it's made in steel, and it's made in 36,000 steel, and it doesn't get the same results quite. But a lot of people like it, so they can use it. But let's start out with the high incidence of crossbites in the deciduous mixed dentition, the deciduous or the mixed. I will use it in literally all crossbites. And I treat them bilaterally because usually there is a physiologic shift.
Right, I would agree with that.
So we retreat it in the mandible centers. That are bilateral crossbites. We'll treat it for arch length deficiencies. In arch where you come up to the age of 8, 2 incisors in, the canines are in, but the laterals are displaced lingually, there's no space for them, and you've got that problem. We would use it in class 3s and put reverse headgears on them. We would use it in class 2s to also assist in the distalizing of a molar, because one of the things that happens with it, and if you analyze the trajectories of this distribution of the forces, you will find how that if you use it the way we do, the upper molar is going to move distally. So I have actually fully corrected class 2 cases with a quad helix appliance. People don't believe that.
Now, do you think you get some, again, getting back to my statement before, that at least theoretically anyway, by making the maxilla wider, it's conceivable that you could have a slight forward posturing of the jaw?
I think so. I think that you'll get a self-activation of the mandible in some children, no question.
I think when I was going through my training, I had heard the statement regarding headgear, for example, that if in cases it had cervical headgear, that many times the clinician would perceive more growth in the mandible.
Yeah.
Does that still fall into the same category? Have you seen that?
I think that that's a possibility. And the way I've explained it is, again, you have to come back. I don't know whether in an interview like this people fully appreciate the concept of arcuate growth of the mandible. In the past, we'd always assumed that the mandible was resorbing on the anterior border of the ramus, having apposition on the posterior border, and the ramus was growing backward and the body was left out here. Well, that just doesn't make sense, because nature's not going to lay down a great big external oblique ridge here only to resorb it in the next moment. So the mandible actually grows vertically and grows on this arc, and as it does so, then this is the part that does the drifting in here. So the gonial angle then drifts around, and the apposition then is on the top of the condyle, top anterior to the condyle. And this arc then is the manner in which the growth is going. The lower teeth then are erupting upward and forward, which actually is the modality that takes place, the mechanism that takes place for the subsequent eruption of the posterior teeth. Now, if you can understand that, you can understand why the slight extrusion that you get, and that's the reason I was interested in your technique that you showed me this morning, and that's exciting to me, because I've been looking for something like that. I didn't know that you were overlaying your cases.
The bonded expander.
The bonded expander. You may be doing a lot more than that, and you realize, because my guess is that you're enjoying the same thing there. Certainly you're not raping that mandible the way that we used to with the techniques that we used.
One of the things that I've found is that when we do this type of therapy and a patient is an end-on class 2, instead of saying, well, we will have to do some type of anteroposterior correction,
no, you don't.
I say, we might have to.
Yeah.
And it's amazing that after a year of doing 6 months of expansion and 6 months of just letting them sit with a upper plate, those class 2s just sort of disappear.
That's right. That's right.
Where does rapid palatal expansion, the anti-Haas type of approach, fit into your philosophy?
I'm a little lost for dates, but I remember when we first started with this. Well, I remember Krebs and Bjork in 1958 when I was there in Europe, showing me their occlusal films and how and of course I went back at that time and started experimenting with the jack screw, taking laminographs, and Rule Bench was just starting with me at that time, and so he got on the circuit and started following closely a lot of the patients that we did rapid expansion with. Bob Wirtz at Illinois had done a lot of work on that. And I was interested, of course, in the total aspects of it in terms of breathing, tongue posture, growth, and all of the associated things that would occur with it. We used it for about 5 years, and it became definitely a part of our treatment. And one day I began to go back and analyze the results of patients that we treated with the rapid palatal expansion. And I, wait a minute. This is no better than what I'd been doing before with the quad helix. And so I made a study. I never published this, but I made a study at about a 5-year level of the results of one versus the other. And so help me, the quad helix, the ones that I'd treated with the W or the quad helix, came out to be better. They came out to be less work, and it was a dirty appliance, and it was hard to get on. You had to separate the teeth. It was a lot of work, and then you had to hold it after you got it split. Then I learned from Story, who visited me and was my house guest for about a week, and he had examined the kind of bone that was present after the palatal split versus the slower expansion, and he found that there was a lot more solid bone that behaved a lot better, that the bone was very mushy after you take one of those things off. And you know, you've had experience, you take it off and it's back, and about as fast as you expanded it if you're not careful.
Well, if you,
so you have to keep it in.
You have to keep an expander in.
You have to keep it in there for 3 months.
Yeah, 3 or 4 months. Anyway,
that's right. So in 3 or 4 months, where are you? You're the same place. You may do it slowly, but I didn't see any difference in what I'd achieved. And who would think that with the upper molar alone, well, with the little finger springs against it, but who would think that that was enough anchorage to divide a whole palate? Nobody would dream of that, any more than they would dream that an extraoral headgear pulling back on only the molars could tip a whole palate back, you see. So this was the thing that was hard to explain with it. So once I learned that, and once I got efficient at putting it in, it was more economical, easier, and I could do intraoral adjustments with it. Then I could just clip it out and put headgears on if I needed it later. Or I could put on auxiliary appliances of any kind. So that's when I left it. And 15 years maybe that I haven't put a jack screw in. That doesn't mean I don't expand, but the majority of it's done with a quad helix, and the majority that I would prefer to do is intraoral adjustments with it, if you have the tools and know how to do it.
Now, you're using a 036 blue alloy or what?
038.
038 blue alloy?
Yeah.
Heat treated or unheat treated?
Untreated. Well, you're going to heat treat a little bit at detachment, but just soldering it on. So it'll be essentially heat treated right where the burn is.
Now, one of the other things that you have talked about for some time is third molars.
Yeah.
And I know that you have advocated in the past the early enucleation of that. Do you want to talk about third molars and from the point of view of early treatment and also from the point of view of its relationship or lack of relationship to lower incisor crowding.
Okay. Let's start from the beginning there again. This idea of third molar crowding has always been controversial. It's no longer controversial with me. I no longer have any doubts about it, and maybe I can explain that. So I have been mindful of third molar problems through my experience with TMJ. It's ironic to me that Brody opposed extraction tremendously, as did Atkinson, but they recommended third molar removal just at the slightest provocation. I don't know whether you knew that.
No, but that's...
And so third molars were nothing to these people. Take them out. So this was a part of the discipline that I experienced very early. Now, in 1951, Spencer Atkinson brought his barrels of skulls to Lexington, Kentucky. The national meeting of the American Association was there. And in fact, that was the first time that I was on the national program. I might depart a little bit from the third molar. I got up to give that paper, and if you can believe it, my mouth went dry, and I couldn't say a single word.
I can't believe that for you. I'm sorry. Isn't
that unbelievable?
Sure.
I got up there, and I could not open my mouth. Can you believe that? Maybe that would be good for the students to know about.
Oh, that's really funny.
That as much speaking that I have done, and the complete lack of concern of me getting up in front of almost any audience today, that when I started, I couldn't open my mouth.
It's really funny.
And I had to look down in the audience, and my wife was there, and I said, "Help me, Patty." Isn't that something?
Yeah. Well, it shows that you're human. That's
so that was 1951, and I was going along studying Atkinson's skulls, and I was the only one who was in the room, so he come along and followed me. He picked up a child's skull, and he says, "Look at this." He says, "Look at that third molar. Look where it is." He says, "Now if you could get in there and enucleate that developing third molar," which was right on a level with the occlusal plane, and it was laying in a cup on the side of the mandible. Hadn't even closed. It was laying on the surface. Now, if you could get in there and take that out at this time, you'd have no lower third molar problem. That was 51. So that stayed in my brain for many years. Then as we came along and we began to get into early treatment, particularly mixed dentition, in which we were intruding the lower molar, we began to see the lower molar back up. I mean, bodily move back. And if the treatment was severe, it would tip back. So now we had the second molar, the first molar over the second molar, and the third molar right up here. So we were impacting second molars with that treatment. Now, not a lot, and every once in a while you'd get in trouble. So here I kept looking at that third molar there all this time. Now we come along in 1970, and I finally discovered this arc, and I said, now I've truly got a long-range forecast. And we begin to see the order that the occlusal plane took to xi point, and we could predict how the lower occlusal plane was going to develop. Well, that did it. That gave me the confidence then that I could predict where a third molar was going to be, whether it's going to be impacted or not. Certainly manually I could do it. And then I went back and took a lot of the cases that we had done previously, and I said, can I predict that we're going to have a molar make or a molar go in this case? And I found out with a study that I did that about 95% of the third molar impactions were predictable. Now, once I could do that, then the next thing was a technique of doing it. So I looked around for several of the surgeons. No, they didn't want to touch it. They well, let's get some animals. Let's do some study. Oh, hell, I don't want to bother with that. I know where it is. Can you do it for me? No, I don't want to mess around. I don't want to cut into those kids. So I kept being frustrated about the whole thing. So one day I told my girl to schedule a third molar enucleation. And busy afternoon, here I had this patient scheduled. I'd forgotten all about it. I had no technique, no nothing. I didn't even have any tools. So I said, okay, let's go. In the meantime, I had picked up technique with the electric cautery, and I worked with that. So I said, here we go. So I knew where it was supposed to be. So I took the, what do you call it? It's not cautery.
That's right.
Huh? Electric cautery machine? Well, it's cautery, but it has a different name. What do we call it? Well, you know what I mean. Anyway, I made a decision there. I said, well, I had periosteo elevator, so I elevated a little bit. Well, how am I going to get this bud out of there? So I looked around at my tools, and I had nothing but a wax spatula.
Okay.
So I went over and burned the wax spatula, got it all sterilized, and took pair of pliers and bent a hook on it, and I made an enucleation with the wax spatula. That was the first one I did. And it was uneventful. Everything went fine. I haven't got any tool that's any better since. It was just a scoop. So I started doing third molar enucleations. Well, I did several myself, and then I showed the technique to a couple of surgeons locally, and they, well, hell, I can do that. If you give me the diagnosis, why, I'll do it for you. So I suppose several hundred, I don't know how many, I lost count, I kept track in the beginning, but the beautiful part of it is that in your mixed dentition cases, you no longer now worry about impacting second molars.
Your second molar will go distally?
Oh, it will fill half the space. The second molar will erupt distally right up into the crypt where the third molar was enucleated.
Now, you said before, just to have you articulate what you're thinking, what do you think the role is of third molars with regard to?
Well, number one, I'm not promiscuous with their removal. I think everybody should understand that. That anything that's not more maybe in the range of only a 30 to maybe 35% probability, if there's that much, I have to have, in other words, about a 70% probability of impaction before I'll enucleate. So I think I'm pretty careful. I mean, that gives me a 20% margin. And as far as I know, I've never made a mistake yet with it. Maybe one little black girl, maybe she had a tremendous amount of growth in the mandible. And I'd taken teeth out on her for a double protection. I do believe that the third molar has a function in it, not like a lot of people think, but I think it helps with the curvus B, hold a condyle back and centric, and I think it adds to the vertical support of the face. So I think that it can, it's it's a tooth after all, and if it can be in and in function, then it's a benefit to the occlusion. So I'm not promiscuous with it. But on the other hand, I do believe that when it doesn't have enough space, that it's going to make itself known. That it's going to, particularly if it comes in at an angle, which it does, and it starts to erupt, it's going to have a force that's going to translate right down the occlusion. I not only believe that, but I believe it can be measured. If we abstract that out in terms of the intrusion force that we know it takes it, calculate that on the base of the root, a force of a third molar can have as much as 25 grams of force coming down the line of occlusion on both sides. That's 25 a side. I had 2 cases in my career, actually 3 now, in which I had 4 to 4 retainers on. And it's not going to crumple these teeth here. The third molar started in, and it buckled the second bicuspid to the lingual. I took the third molars out, and the second molars, second bicuspids, went back into position with no orthodontic treatment.
Interesting.
How would you, I mean, I'm a farm boy, and I've looked at a mule's rear end for long years, and I think there's a good common horse sense. That's common mule sense.
Yeah.
That if you have a patient like that, that's pretty good evidence to me that a third molar has been the culprit in that situation. So I don't have any doubts at all anymore that a third molar can cause a break in the lower arch. Too many cases clinically you've seen happen, even in patients who had normal occlusions. And people say, well, what about those cases that break when there's no third molar present? Well, what about that? It doesn't mean that the third molar is the only force. The first molar and the second molar still is in there operating. The third is just adding to the whole mesial thrust.
You think that a latent mandibular growth can have something to do with lower incisor crowding?
Particularly if it's vertical.
Why vertical? Because of then the...
Well, let's look geometrically. If I have an occlusal plane here, well, let's see if I can draw my hands here, maybe for the audience here. Let's say that this is a lower incisor and this is a mandible.
Mm-hmm.
Now, with normal growth, this thing is kind of doing this, isn't it?
Mm-hmm.
Okay. Now let's say that we have late growth and the patient is growing vertically. Now, as the mandible is growing, it's tipping the lower molars, the lower incisors out. If it grows like this, the occlusal plane is doing this. It's throwing the lower incisors against a lip, and the lip is going to be increased in tension, and now it's going to break up front. So if you have late growth, and particularly if it's vertical, then you're going to have this kind of an environment right against this part of the lip, which is disaster in a case like that. And that's the reason why in these vertical growth patterns you're obliged to extract, sometimes even with a good lower arch. That this is what's ahead for that case. And here you have the vertical growth taking place, more denture height developing, lip strain, and the teeth being thrown against it. Now you have to use your imagination, and you have to see cases in which this takes place, but once you get that, it's very clear that that's a possibility. So that's another modality of crowding.
Sort of a related question, and I'm sure if you're like me, you're asked this question every time you open your mouth. Somebody says, what do you think of second molar extractions?
Well, I did it in my daughter, I did it in my wife. I think it has a place. But to have it as a substitute for third molar enucleation, if I'd had the possibility of taking the third molars out in an enucleated way, as far as I'm concerned, there's no comparison, because a lot of times the occlusion you end up with, that third molar, a lot of times, if you take out four second molars, the upper third is going to come in faster than the lower. That's pretty well known.
Okay.
Now, that comes down in here. The third molar then has to close up all of that space. It has to already upright, and a lot of times it's leaning forward. The occlusal plane is down, and so you don't get a real good occlusion with the third molars when you take out 4 second molars, unless you go in and treat it at a late stage. So I'm not saying that it doesn't have its place, but to use that as a substitute for bicuspids, to use that as a substitute for a philosophy of mandibular posturing and bone growing and all of this, I don't buy it. I think it has a place, and I've done it, but I think the other modalities we have are superior to it.
Now, you mentioned about the lower labial region, and something that's of particularly concern to me and my family.
Yeah.
Is this question of, what do you call it, a sublabial release?
Sublabial release, yes.
You want to describe that a bit and how that fits into what we're talking about?
Well, I suppose my respect for the lower lip started with a patient that McGonigal in my class treated. As you know, we had McGonigal and Kincaid from Ohio, and we had from Illinois there we had Eb King. And from Baltimore, we had, in New York, we had Sam Przansky. myself from Indiana, and Walter's from over here at Niles, Michigan, and Eddie Wong from Hawaii, and Guy Wood, who went to Portland, and that constituted our class at that time. I had, in January of our class, we took impressions on the waiting list, and we took them all in plaster, incidentally. Did you know that?
I would imagine that that might be the case.
That was the discipline, and we trimmed our models by hand. We weren't permitted to use a model trimmer. Did you know that?
No, I didn't know that. Jeez.
Can you imagine cutting those with a jack plane and filing them and polishing them? Your hands would be bleeding. You wanted discipline. That was discipline. Well, anyway, I took impressions of this patient. Her name was Erica Rafting. She had the most vicious lower lip habit that I have ever seen. Brody had never seen anything like it. I happened to take her on the waiting list, and I know how tough that lip was to get an impression in that kid's mouth. Anyway, McGonigal came up to a case that Brody had selected for his day, and they elected to put a shield on that case to strap up the lower arch, as Brody liked to do, and he built a shield off of an 022, 028 wire, double back, soldered, and this shield was out there to hold the lower lip away to let these incisors. Now, if you can imagine a case with 8 front teeth all in a line, that's just about the way it was, all crumpled up and all in one straight line here. So I was there watching the day that McGonigal put it in. And he put it out there maybe 4 millimeters, 5 millimeters, maybe that much, ahead of the lower arch. That patient came back in 2 weeks, and that appliance was completely buried in her lip. It was up and under this way and over the top this way. It was buried. That lip was so tight that it just wrapped all the way around that thing. She was bleeding all over the place. They stayed with it. They backed it up a little bit, and it's kind of experimental because I don't think Brody had ever used it before. He called it a shield. And I followed that case even after McGonigal had left. Well, can you imagine that lower lip was so strong that he treated the case with class 2 intermaxillary elastics and got all the teeth in the lower arch, and the lower molar ended up posterior to where it started, all due to the contraction of that lower lip. So that experience I had before I went to California. Then when I went to California, of course, I was on headgears, and I entertained the idea of making that simpler and putting buccal tubes on the lower molars and putting in what I called a bumper to push the lower teeth, to push the lower lip out so that we could let the lower teeth have space. Well, I began to use that quite a bit. And I found that within 2 weeks, some of the times, you got a change in the oral environment that was quite favorable. It was amazing because you wouldn't notice that the child even had it in a couple 3 weeks. Well, anyway, on those severe cases, when I put it all the way down in the sulcus here, not on this part of the lip, this is loose and flaccid, and it's not going to have much resistance. But if you get it down into this level right here, that is extremely tight. And we found that we were actually moving molars bodily distally with this bumper, and of course impacting the back teeth. So that gave me respect then. If that could do that with a bumper, then the whole lip intact, holding the occlusal plane down, that's a part of our whole anchorage belief, as you understand. And that became the problem. Now, what to do in those patients in which you deliberately wanted to displace the lower arch forward, you didn't want to treat to the environment. How are we going to handle that? Well, for several years I went on lip blowing exercises, trying to stretch it, pursing the upper and blowing it. I got that technique from a guy from Scotland who came through Illinois one time. And so that's what we tried to do. This was long and hard, and you wouldn't get cooperation of the patient. So along about 10 years ago or so, we entertained the idea of surgically relieving the lower lip. I had worked with Warren Hamula 10 years before that, when he, together with the surgeons and periodontists at Colorado Springs, Colorado, had done some experimental work, and they'd sort of given it up because they didn't quite feel that it was enough difference to make a difference. But they were only working down in here. They weren't working up in here. They were working down in here, relieving the mentalis. They felt that it was just the mentalis, mentalis, mentalis. Well, no, that's not what it is, because this is not mentalis up here. The mentalis starts here and goes down. This crease is right here. So, well, that has to be then either the orbicularosaurus, the incisivus inferioris, that's a horizontal muscle going across, or the quadratus labii. And according to Cunningham, almost a quarter of the population has a union of the quadratus in the midline across the chin, these buttons on the chin that you see. Well, remembering that, I said, well, maybe the problem then is one of transecting that muscle mass that's going from side to side, because this is all hypertrophied. You pick that up in a patient here, class 2 division 2 or even 1, in which they've done this. This muscle has, it's like weightlifters. It's just, and it's even gone to the place where it's advanced now maybe to fibrous connective tissue. So we had a patient on surgical table that was getting a genioplasty done, and I'd been talking to the plastic surgeon about this for a long time, Henry Kawamoto, who I work with a great deal. And he says, wait a minute, what is that you've been talking about? We had this patient with the lip all laid open, and he pulled it upside down and looked at it. I said, that's it, right there. So he says, you want to do this? We cut, and I said, you want to take that out? So he stripped it out. That's what I want to do. So the first one we did was on a patient that had an advancing genioplasty with this tight lip. And even with an advancing genioplasty, you're going to end up with some of these creases in here that really are tough. And so this needs to be done even though you're doing a chin procedure. So with that then, I started experimenting with patients, and I started, and to date I've done 90 of them.
Interesting.
So to release that, instead of treating the teeth to the tight lip, then doing something about the lip so that you could go ahead and unfold a denture and have the great smile and the fullness.
Can you just very briefly describe the procedure?
Yeah. We will go in the sulcus. First of all, we'll give an injection just by infiltration, 1 or 2 carpals, 1 or 1.5 carpals, all the way around, so that we go all the way out to the mental foramina. We don't go into the mental foramina, we just give a good infiltration. 2 reasons. Number 1, we have epinephrine in it, so we'll control a little bleeding with it. Then after that's taken, we will go in and make an incision right at the midline, right across the raphe, an incision that's about 12 millimeters long. We then will go in with the periosteal elevator, and we'll lift the mentalis attachment right off of the little fossa on either side. There's a little fossa there and a little ridge on the mandible that you'll see, a little transverse ridge at the symphysis, almost immediately lateral to the protuberance menti, just a little bit above it. So we'll go in and elevate that. And then we'll proceed out to the upper border of the mental tubercle on either side. Now below that is the triangularis. Right here at the mental tubercle, right along here is the quadratus origin. And it comes up and comes in here. So what we want to do is to take that down, free that up. Now once we do that, then we can lay the lip out quite easily, and we can see then the integument of this part of the lip. And we'll examine it, and most of the time we will see a yellowish, whitish raphe that is much bigger than it is in the typical case.
Okay.
So we go in and take that out, and then with experience excise a little bit to the lateral, particularly in males, and loosen that lip up, close it up, and that's the procedure. Okay.
To summarize some of the material that we've talked about by asking you, Rick, of all the things that you have done in orthodontics, and I think there are you would be hard-pressed to find anyone that's contributed more to the field of orthodontics in as variety of ways as you have. What are the things that you really feel are the most important contributions that you've made to the field?
I've been asked that before, and I have said that maybe history would have to say that rather than me. What the effects of my work, my teachings, my influence have been will have to stand up with the test of time.
Now, I know that you're an intrinsically modest individual.
Yeah.
So why don't you just come on, get over that and tell me
well,
what it is that you really think.
I suppose if nothing more, I would say the enforcement, maybe the reinforcement of biology into the thinking of orthodontics rather than just mechanics. I think what I would like to be known of is maybe someone who brought the whole patient to mind rather than a set of teeth. I have learned that even graduate orthodontists that have come have the tendency to think teeth, think teeth, think teeth. Think in terms of driving teeth, think in terms of moving teeth themselves, and getting in and getting something that mechanically is going to force things into the mold that they would like to see accomplished. I believe if there is any contribution I've made, number one is that the patient is an individual and that you must rely on principles. There's no laws, maybe a few things that are near laws, like the archaeal growth may be a law. Mm-hmm. I'm not sure. Certainly it's a strong principle. A principle is a truth that is generally trustworthy, but it's not without exception. A law has no exception. That's the difference there. So maybe, if nothing more, I have been responsible for thinking beyond the level of the teeth in orthodontics. Thinking in terms of growth, of orthopedic change, of physiology, physiology of the oral cavity, physiology of the nasal cavity, physiology of the nasopharyngeal apparatus, physiology of the whole head, and of course the TMJ and the function of occlusion. So I think if you abstract the trend that my work has followed, it is, as you said, as you suggested, where did I get my interest in anatomy and physiology, kinesiology? I think this is the substance that really is there. That if I've done anything, it has been to bring to the profession the awareness that there's a whole patient sitting behind that set of teeth, that they're growing, and that there's blood, and there's nerves, and there's muscle, and there's soft tissue, connective tissues, and that all of these has to be thought of in the diagnosis and any therapeutic regime you're going to offer. It has to be extracted in this light. It has to be applied in this light. So my greatest contribution, I hope, would be that not just an isolated contribution here or there, the quad helix, the utility, the sectioning of arches, the orthopedics with extraoral therapy, even mandibular posturing in the concepts that we entertain today. The diagnosis and treatment of TMJ. To me, it's all a part of the fact that the orthodontist is a professional, that it's just not going and taking a weekend course at, I call them Holiday Inn specials, that this is not the making of an orthodontist. It's not the making of an oral orthopedist. That looking at it in its totality, holistic, if you want to even add that word, which I don't like. But maybe that's my greatest contribution. What do you think?
Well, I think from a diagnosis standpoint, I think that your analysis, for example, you know, clearly a lot of the work that I've done is based on your material, as you well know. How did that all come about, the actual construction of your analysis?
Okay, let's go through that. I think that would be worth knowing. As I think I said earlier, our class in 1948 had to teach Downs analysis to the graduates that came back who were getting it for the first time. I remember the case name of the boy was Swanson. It was my patient. It was a class 1 extraction case that I had done for Downs. And what I had done was to recopy all this. I had to make this many drawings because we had no copy machines. And so we had to do all of those drawings for the 10 graduates that so I had the problem as a graduate student before the class was over of teaching Downs analysis. Well, I ran into problems in my mind even of how to do it. And so it wasn't very long that with the work that I had done with tomography and the work in the lateral planes here, and with the mid-sagittal sections that I had made, that I started altering Downs analysis. So I started with Downs, plain and simple. The first thing that I discovered was that the ear rod wasn't in the ear hole.
Okay.
When I would take patients and put them in the cephalometer, and then I would take laminographs, and I would find out how far indeed we had missed it. The first thing I did was to then put markers on skulls and take x-rays. And I remember Downs coming to my office. This is the thing that bothered him a great deal. I had to prove to him that the ear rod was not in the ear hole. And Downs came to California and spent some time with me. Did you know that?
No.
And we got some skulls, and I put, well, we used to use gold soldering and glue them in place so that we could study them in the x-ray because they're very vivid in the x-ray. So that was one of the first changes I made, that we would no longer accept the ear rod of the cephalometer on the wall to register, as Tweed was doing. Some institutions still do. And it's just unthinkable to me that after all the writing and all these years that anyone would do that. And I understand that only this year the Tweed Society went on record as now saying that you have to go to the Tryporion this year, after how many years? 30 years, 40 years that I've been working with it. That was one of the first changes I made. The second one was to add Bayesian-Nasion, because up until that time no one was using Bayesian. Bayesian had been used anthropologically many years before. But when Broadbent did his work, he had so much paraphernalia, particularly in the young patient, that he was covering Bayesian. So a structure beyond the washers and all of the mechanics that he had in his cephalometer, that's the reason he had to go back to Bolton's Point, which was on the posterior fossa of the occipital condyle. So now I come along with the mid-sagittal laminograph, and there was the Bayesian slapping me in the face. I mean, it was so vivid that I couldn't believe that anybody couldn't see it on a head film. So I went, oh, well, there it is, there it is, there it is. And we found out later that a lot of people were confusing it with the crest of the occipital condyle, which comes up like this, and a lot of people would trace it with a little comma on it. They were tracing the occipital condyle. So to find it, know the anatomy there, get in and look at it and look at its variation. So we now added Bayesian. And as I began to superimpose then, and this is all in the late 40s and early 50s, as I began to superimpose, I began to find that Sella was moving around from Bayesian to Nasion, that this angle wasn't constant, And that's the reason in Lewis's, I was trying to get at some of those findings that he had, because I was familiar with that when he did them. Mm-hmm. And of course I went back and reviewed them just the night before I got here, and just looked them over again to remind myself of what he had done, because I was pretty well aware of that research together with Brody's stuff and all of this that had been done in the cranial base. And then of course this with Bjork and all, this is the reason why I had abandoned Sella altogether after the computer studies and when I saw what was going there. So Bayesian-Nasion became the plane of reference for longitudinal work. And so the next thing then, or about simultaneously with that, was that I began to take interest in the lower incisor. Downs, as you know, had measured the lower incisor not in position. He'd measured the upper incisor to the APO plane. Mm-hmm. But he hadn't measured the lower incisor. It was in the angle to the mandible and the angle to the occlusal plane, which did not describe its spatial position, or in space. It only had to do with its angulation. So one day I was playing around and I said, well, let's measure the lower incisor to the APO plane. And I had measured a number of patients, and I had, I think it was 8 or 9, maybe 15, I forget exactly how many. But I'd gone down to Elsie Gerlach in the Department of Pediatrics there in pedodontics in the school. And I said, give me a sample of beautiful, normal, mixed dentition children. Mm-hmm. And so she began to collect them as they would come through. I took them up, took joint x-rays on them, and took head films on them. And I found in a number of these cases a mean of 22 degrees and a position of lower incisors that was 1 millimeter ahead of the APO plane in that sample. Mm-hmm. Of beautiful, beautiful normal occlusions in children. And I said, God, that's where we'd like to go. If that's where they are naturally, then, you know, there was a variation mm-hmm. all the way from 0 out to +4, but they averaged, when I put it on the table, of 1 millimeter ahead. So that took me then to the lower incisor to APO. Then I began to examine older patients and growth, and I found that once it got in there, it had a tendency for order. That as the mandible grew and the mandible began to overtake it, the lower incisor tended to hold its position with growth, so it became a manifestation of age and facial pattern, because we found in convex faces with normal occlusions, lower incisors be out here. Mm-hmm. Concave faces, normal occlusion, lower incisor would be back here. So what Tweed was really talking about was not relating the lower incisor to the mandible, to the Frankfurt plane. What he'd forgotten was that he had to put it in the profile.
You usually cite Benny Solo's work.
Okay.
Yeah, you want to talk about that with regard to the position of the lower incisor?
Well, yes. Benny did a marvelous study, which I think was a follow-up on the material that Lindegard had started in the 50s. Lindegard in 1957 published an article in which he tried to find, he was an MD incidentally, and for his thesis as an MD, I met him in 1958 and discussed his work with him. But he did it under Bjork, with Bjork's material, and he tried to find out whether or not there was any association with anything in the body, with anything in the head. And he found out that the only thing that he could even get the slightest correlation was the length of Sella-Nasion with the length of the femur. That's very weak. Now Solo comes along with his PhD and published in 1966 a big monogram on craniofacial associations. And what he had done is to go to the internal parts of the face and see whether there's anything that we could correlate with the rest of the body, any information that we could get outside of the head film that was going to give us any useful information. Well, he confirmed largely what Lindegard had shown before, that there was really not much. What you have is what you got is what you see on the head film. Yeah. Now that doesn't include the neck. I think there is information in the neck, and I would go back and question, because I don't think they measured height and associations there. I would question some of the conclusions that Solo made with regard to things outside the skull, but it's still on the head film. Now, Solo comes in and he starts doing all of these studies, and his was a really first great computer study, and I have to give Benny Solo credit for that. He thinks that I didn't recognize maybe enough of their work, but I certainly do. I abstracted this down, and I said, well, there's largely 4 conclusions that were made with Solo's work. Number 1, that the position of the cranial base, or the angulation morphology of the cranial base, has no predictable relationship with the relationship of the jaws. We had assumed maybe with an obtuse cranial base that the posterior cranial base was going to be pulled backward, and it was going to induce perhaps a class 2 relationship. That didn't obtain. Now, the reasons for that are pretty obvious, that if you go selenasion, you're in the mid-sagittal plane. If you go celebasion, you're in the mid-sagittal plane. But the reference of the condyle is in the temporal bone, which is in the lateral plane. So that's the problem, that you're not dealing with structures that are all in the same plane. And so we could largely then, in prediction, forget the use of Bayesian as a tool to predict where the things were going to go.
Bayesian or Sella?
Bayesian.
Okay.
See, well, it's from Sella. It would be Sella and Bayesian.
Oh, all right. Okay.
You see, either one, it's where you sit is where you stand. You know, where you stand on the subject largely is where you sit with it. Okay. So he said that. Now, he said, however, that in the nasopharynx, that it made a difference. Well, that stands to reason true, because that goes back with my earlier work in '53, where I described the morphology of the cranial base in submucous cleft palate cases and in pharyngeal palatal incompetency. So that kind of fit, that it did have a secondary effect on the oral environment through the relationship of the opening or closing of the nasopharynx by the morphology of the base of the skull. So he said that it had something to do with the nasopharyngeal apparatus, but as far as predicting where the jaws could go, forget it. Okay. Now the third thing is the most interesting of all. What he did was to relate the teeth to both jaws, to the upper jaw and to the lower jaw, with the methods he was using. And don't forget, he was also using frontals. He analyzed frontal head films at that time. In fact, Izzy came up with about the same measurements that I did, and I wasn't conscious that he did. He said that I stole them. I don't think I did, because I wasn't aware that if I'd have stolen them, I'd have given him credit. For sure I would have. But anyway, the thing that he said was that there was more association of the lower teeth with the upper jaw than there was with the mandible. Furthermore, there was more association of the upper teeth with the mandible than there was with the maxilla. Now think about that for a minute. All through the history of orthodontics, we had tried to relate the teeth to the mandible and relate the upper teeth to the maxilla, and then work like hell to try to get the two aligned with each other. Now he comes along and says the lower teeth are more inclined to match the upper jaw. Well, how could that be? Well, for instance, take a patient that has a convexity to the pattern. If they're going to have normal occlusions, naturally, what's going to happen? The lower teeth are going to have to be out here. The upper teeth are going to be back here. So they're not related to the maxilla. They're related to the mandible. Well, the minute I heard this, read it, I latched onto it. Why? Because it was consistent with my own thinking, exactly with my own thinking, that the job of the orthodontist is to harmonize the teeth between the two bases that you're dealing with. They called it compensation. They called it the teeth compensating to the pattern, to the morphologic pattern the patient had. The same thing obtains in the frontal. If you have a wide mandible and a narrow maxilla, the upper teeth have to be here and the lower teeth have to be in here to be in harmony. And it gives you the idea that the functional occlusal plane has to be in neutral position between the upper and lower jaws. That's where nature is going to have to put these teeth. Going to have to rub in class 3, it's the lower teeth are erupted here and the upper teeth are out here. So before you do surgery, you do that, don't you?
Sure.
So when you make them, they'll be in the right position. If you don't do that, you've still got this, when you get a class 3 treated. Same thing in a class 2 if you're going to operate the maxilla there. So that was his third principle. I call it the 4 solo principles. Now the last one of the 4 simply was that when you have compensations that were not made by nature, that the orthodontist had to come in and artificially produce positions which would be harmonious with the skeletal pattern.
No, so what you're...
Isn't that beautiful?
Yeah, so what you're saying, though, is that if you set up an arbitrary 90 degree to the mandibular plane for the lower incisor position...
It's nonsense.
Yeah.
It's absolutely absurd. In Brody's study in class 2, he found the normal lower incisor variable 43 degrees. In normal occlusions, going back to the studies of, heck, this was in 50. The things that Lewis wrote that he forgot he wrote. The variations in normal occlusions was 28 degrees with the lower incisor. Well, how can anybody make a sense with a range of 28 degrees with the lower incisor when you're going to try to put it within half a degree? It's just total nonsense.
Let me ask you a little bit more difficult question. You've been in orthodontics for 40 years. What are your biggest disappointments? What are the things that either you thought were right that were wrong, or that's something that you think should have been done that hasn't been done, or something that you feel strongly should be accepted by the profession that hasn't been?
Number one is probably my biggest disappointment, is the lack of respect for what a computer can do for them in diagnosis and the application of it to clinical use.
Tell me more.
The average person, well, let's go back through history. How much time does the average clinician spend on diagnosis?
I don't know. I have no idea.
2 minutes? 3 minutes? That's a lot. They shoot from the hip. They make value judgments. Most orthodontists clinically for years and years and years, and I think still do, react to the amount of arch length in the lower arch. That's the number one consideration they have. How much crowding do I have? Then they begin to look a little bit, how much can I expand? And if I can't, I can take 4 teeth out.
Okay.
Now, how long does it take you to treat?
Not very long.
The patient sits in a chair and you've got it done. Now, that to me is disappointing, that despite all of the sophistication we're supposed to have, all of the knowledge that we're supposed to bring in a biologic way to the patient, and when you really sit down and look at it and you see what the average guy's thinking is, throw a set of models out on the table and let people start using value judgments and see what kind of very certain, very almost emotional reaction people will make to that. With just the limited information you see on a set of casts, how much crowding have you got in the lower arch? Let me see the face. See if I can take a shot at it. Now tell me if I'm wrong. But I think that came to be what it really was.
But do you think, let me rephrase your disappointment.
Okay.
Maybe what you're saying is that it's not only the fact that a computer-assisted diagnosis is helpful, but maybe the fact that people don't spend enough time diagnosing, period.
Or prognosing.
Or prognosing, yeah.
I think that we should clarify what is diagnosis and what is prognosis and what maybe is treatment planning, because I think that should be put out there where people would know. My feeling is that they're inadequate in all three. I think that people will throw a technique at a patient. Mm-hmm. That's my biggest disappointment, is that we latch on to techniques and we throw the treatment on the patient. To me, that is completely dehumanizing an individual. Mm-hmm. To think that I would go someplace and get somebody's standard way of treating a patient that's thrown at me rather than something that is designed specifically for me, for all of my individual needs, and anticipating everything that is anticipatable at that time. To me, that is probably the single most greatest disappointment that I've had in my profession.
What else?
The second one would be to ignore the patient in terms of biology. As you know, today, one of my chief thrusts is in the field of a biologic support for a patient. We assume that a patient's going to be healthy. We're spoiled. We can get by with a lot. Nature lets us get by with a lot. But I've dealt with a lot of sick patients in my time in temporomandibular joint disease. I've done studies in geriatrics, geriodontics. I did a 10-year study from 1959 to 1969. And I know that people are losing their teeth. I know that dentistry is failing. And dentistry is failing because they've thought of nothing but mechanics. Plugging up a hole mechanically, grinding the teeth mechanically, arranging the teeth on a typodont mechanically. When biology is really what we should be dealing with. We should be working with the immune system, because in my feeling, abstractively, I think that the loss of teeth in periodontal disease is a loss of the immune system. The bacteria is getting to the patient. That together with trauma, maybe. That superimposed on everything else. But dentistry is not successful in getting patients to last a lifetime. If you want to get an example of that, if you dare, go to some of the rest homes and look at the oral conditions and look at the plight of many of these people that get into senility without teeth, can't even wear artificial teeth. I think this is one of the reasons that implants are getting such a complete trend today. Everybody's interested in them, of trying to finally do something about replacing what we shouldn't have lost in the first place with implants. That, to me, is another disappointment, that we have not been able to save teeth. And having my own family, my mother had all of her teeth lost when she was 22 years of age. Wow. She wore the same set of dentures for 44 years, and her mouth was destroyed. The one thing she asked me in her terminal years, I said, is there anything that you want, anything I can do for you? I'd be happy to. Is there anything you can do with my teeth? The only request she could make, that's something I couldn't do anything about. And here I am, one of the authorities in my field, and I had to say, Mom, we've done the best we can. That's pretty sad. Yeah. It really is. And we shouldn't think in terms of people coming through stages. We should think of people having teeth until the rest of the body breaks down, not having teeth, the primary part of breakdown in a body. Don't you like that? It's been a disappointment to me because my profession has failed.
What else? Anything else comes to mind?
The next thing would be the failure of adaptation of the techniques that I think that are available to us. I think that there's entirely too much today in terms of what people call the straight wire philosophy.
Go ahead, tell me more.
Wait until all of the teeth are in, get a hold of all of them, and then start throwing wire after wire through to level things out, and throwing one arch at the other until you're blue in the face, and then if you don't work, take 4 teeth out and do it that way.
Isn't that sort of a throwback to the primary edgewise philosophy?
It's the old stuff all warmed over just with light wires. So it's not a part of biology. Again, it's a technique. Now, if you've got the bite leveled and if you've got things, your initial phases have all been worked out and things like that, we do it. There's a place for it. But as a standard way to do things, I'm very disappointed that people would jump on to that with no more thinking than what they have. Again, it gets back to my first disappointment.
From your perspective of 40 years or so, what's new? Where are we going in the next 5, 10, 20 years? Where's orthodontics going to be? Is it going to be all adjunct of or part of a general practice? Are we going to see orthodontics as a specialty continue? What do you think?
Well, let's look at this. Bob McGonigal was president or president-elect of American Association in 1976. He called me up and he said, I would like for you to give the Mershon lecture in New York in 1976. I said, well, what do you want me to talk about? He says, I would like for you to expand on what you talked about in your Ketchum address in 1975, which was in, were you there?
I was in East Germany, as a matter of fact.
Yeah. Well, I got the Ketchum Award in
75,
Las
right?
Vegas
Yes, I know.
in 75. And I made an address, and I talked, it was sort of a plea for orthodontics, how much I respected it, and I broke down when I gave the talk. In fact, I had tears in my eyes and so forth. And I'm a pushover anyway. I'm a real softy. And so I got this paper together, and I had done some research in it. I had gone into the Journal of Dental Education, and I had read a particular article by somebody whose name I forget now. Maybe I didn't want to remember it. But anyway, I said at that time that I could see that the orthodontist should be the central figure in dentistry. Instead of being the specialist, the orthodontist was in a position to be a diagnostician, and that he shouldn't be thinking just in terms of getting the adolescent child in with the right malocclusion, that he should be taking on problems of the TMJ. Why? Because only he can finish him. He should be thinking in terms of early intervention rather than letting the pedodontist mess around with the kid, and then if he fails, get the patient back, and a few things in the thinking. That if the orthodontist has this, if occlusion becomes the main thrust in all of dentistry, then it's the orthodontist, who should be a master of occlusion, that should be in a position to be the diagnostician. That would put the general dentist who is doing fillings in the role of the specialist for a filling.
Mm-hmm.
And it would completely change the person's attitude about his profession. Now, I published that, or I wrote that in 1976. At that time, Todd Duo was the editor of the journal. I sent it to him, but he wouldn't publish it. He didn't say in so many words, but I knew why he didn't, and he thought it'd be too detrimental to the profession, who was relying on general practitioners to feed them. Now, that was 10 years after the 68 paper that we talked about. Now let's go to today, where we are now. In California, at least, almost 60% of the orthodontics that's done is done by general practitioners. Did you know that?
It's about the same here, maybe even higher.
This means that the orthodontist is no longer getting referrals with orthodontic cases. Now, I'll ask you a question. If the orthodontist is not getting referred by a general practitioner, how can he expect to get one back that drifts into the orthodontic practice away from him? How does he expect the orthodontist, on an economic basis, well, even on an ethical basis, how does he expect to get that patient back?
I don't know.
Where does that put the orthodontist then? If an orthodontist treats a patient, in the patient's mind, the orthodontist is responsible for that relapse if it takes place.
Mm-hmm.
You and I both have patients coming back, and they don't say so in so many words. Here they sit, they're getting crowding in the lower incisor, and they say, well, you treated it, it's your problem.
Yeah, I would.
Isn't that right?
Sure.
So if I'm going to be held accountable for it, and if it goes to the general dentist and he says, gosh, who treated you? I can do that good. If you're going to fail like that, I can't do any worse. So where does that put the orthodontist? Right behind the 8 ball. Now, we can either whimper, put our tails between our legs, and run away, or we can say, that's our responsibility, and we're going to do like the periodontist does. What does the periodontist do?
Puts patients on recall.
He puts patients on recall. So my idea is that we never discharge a patient. And that's what we practice in the office today. When we get through with the patient, we say, you're going to be on recall now. We offer you a retainer, but we have a hygienist. That patient comes back for hygiene care. We will do any adjustment on the occlusion that patient needs because we're the authority in occlusion. Where does anybody else come into the game then?
Specialist for fillings.
A specialist for fillings. And if they follow us right, they won't need even that because we don't have caries like we used to. That gets periodontal disease. But if with our biologic support, with our health and wellness programs, they shouldn't get periodontal disease either. They shouldn't get TMJ disease. So where does the general dentist come in? He doesn't.
How much?
So we've got the whole thing in our lap, but we've been so inhibited because we've had to rely and suck it up every time that we get in the presence of a bunch of general practitioners that we're completely humiliated, really. I don't believe that. I think that dentistry is going to have to do it. They're going to have to take more of an active place in the body as a whole. And so, in my opinion, orthodontics has this opportunity if it's big enough to take it. It's a whole question now of whether or not orthodontics, or who it is that's going to do it, somebody's job. Who's it going to be? It should be the orthodontist.
We've gone on for about 2.5 hours now, and I think that we're probably about ready to wind it up. Have you got any other final comments or thoughts or reflections on having existed as long as you are and not being senile, as far as I can tell? You seem to specialize in...
I'm very proud of the fact that I'll be 67 in about 25 days. And I just sired a new little baby. And it's just the most delightful thing that ever happened. She's just the sweetest little thing, and every time she lights up, it makes me feel good. And so I suppose that. The other thing, I think I have good genetics, maybe. But the other thing, I think, have you read the work of Norman Cousins?
Yes.
I think a great deal of illness, and I think a great deal of aging has to do with your attitude. And I suppose it's because I still think young. I still think that I'm a young person, certainly young at heart. I don't think of myself as an old person, so maybe that's one of the
You don't
things.
look like an old person either, so.
So I think that's it. And
well, I thank you for indulging in our curiosity today, but I think that this certainly should be a very good overview of your past 40 years, and I hope that there's another 40 or more coming.
The thing that I think we did leave out was all of my work on the TMJ, which has been a good part of my
We'll do that on another day.
The thing that we didn't get was work on aesthetics, which I think is a major subject. And then someday maybe we can add to the biologic idea that I think is emerging, that it's one part of the environment that we do have some control over. And it's one place that we should be giving our attention to a great deal more.
Well, I think you should be more than congratulated and feel pretty damn good about what you've contributed.
Well, I do.
You're a very special person, and
Well,
I don't think there's anybody in orthodontics that would not recognize the incredible contributions that you've made.
Well, that's great.
Thank you.
Thank you.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.